Hello, thank you for joining us. I'm Dr. Scot Hutchison. Thanks for tuning in to Hutchison's Huddle. And today's topic is about ectopic or tubal pregnancies. But first, let me remind you that on the 24th of September, we're going to be doing one of these about polycystic ovary syndrome, because this is Polycystic Ovary Syndrome Month. And if you would like, you can always look back on our Facebook page and look at the other huddles that I've done with some really fine OBGYN doctors, Drs. Aaron Sperry, Celia Valenzuela, Elena Lackenpaul, and Kevin Murphy. So they are all awesome. If you want to take a look at those various topics, but all very useful and good patient education materials. So today, I have some questions that some people have submitted about tubal pregnancies and ectopic pregnancies. And so let's just kind of run down the basics of all that, because it can be very confusing. So tubal pregnancies are in the tube, obviously. Ectopic pregnancy just refers to pregnancies that are not in the right place in the uterine cavity. So, and they can be everywhere. When I was back in Baltimore, we had one woman who had a pregnancy on her spleen. I've seen them a couple of times in the pelvic sidewall, once on the rectum, many times or a few times on the ovaries, but most of them are going to be in the fallopian tubes. The risk of an ectopic pregnancy, generally speaking, is about 1 in 50, or about 2%. Now, your risk can be higher than that if, for example, if you're a smoker. So smokers are somewhere around 2.5 times, maybe even in one study said 20 times more likely to have tubal pregnancies. I don't know if that's really all that true, but I would probably say about 2.5 times more likely. So instead of 2%, looking at maybe 6% or 7%, something like that. If you have a history of pelvic infection, that also can increase your chances of pregnancy, because if the tubes are damaged, they don't tend to contract very well. And they may have little scarring areas within the tube that make it very difficult for the embryo to get through the fallopian tube and down into the uterine cavity. And so they make the old scarring may cause the embryo to hang up in the fallopian tube and not be delivered into the uterine cavity at day 5 or 6 of embryonic life. And then they may just stick there and start to grow in the fallopian tube. The smoking, incidentally, is probably because smoking, because it's nicotine, and there are receptors for smooth muscle called nicotinic receptors. So smoking alters the way the tubes move. So that probably is one of the reasons why tubal pregnancies are more common in smokers than non-smokers. So how do you find out if you've had a pelvic infection? Well, we like everybody kind of to have, anybody with new sexual partners, anybody who's in that anybody who becomes sexually active in their early life through about age 30, 35, until they have a stable monogamous partner, they should probably be screened, or should be screened, for gonorrhea and chlamydia every year, along with other sexually transmitted infections. The numbers of women who've been exposed to chlamydia, which is an organism that can really damage the fallopian tubes and not really let you know it, is probably about 2/3 of the population. So the good thing is that a lot of people who get chlamydia, it just lives in the cervix and it's not really going upstairs and damaging the fallopian tubes. But on the other hand, you can have some tubal damage and never really know it. So tubal infections can cause scarring around the fallopian tubes. It can also interfere with the eggs getting picked up, and then that can lead to pregnancies not going where they're supposed to be. We think that a lot of the ovarian pregnancies occur because the follicle that contains the egg in the ovary may actually rupture really nicely and release the fallopian tube fluid, but the egg may not leave the ovary. And so the sperm, we humans, we got some weird stuff going on. And one of our anatomical things that is different from a lot of other species is that the sperm can swim out of the fallopian tube unfettered all the way up to the diaphragm. But they will follow the chemotactic or kind of chemical signature of the eggs. And we think that they can actually follow that egg and get into the ovary, fertilize the egg in the ovary, and then the embryo may just develop in the ovary. So historically, pregnancies in the ovary were treated by taking out the whole ovary, but we don't do that anymore. And we'll talk more about treatment, but you can remove those surgically successfully most of the time if you catch them early enough. And you can also, treat them with a medication called methotrexate. And we'll talk about that in a second here too. But anyway, so I think that when we talk about tubal pregnancies, ectopic pregnancies, it's really important to get those caught as early as humanly possible. And to even back up further than that, like know what your risk factors are. Have you had chlamydia before? Because if you do, boy, the minute you get pregnant, you should be getting blood pregnancy tests and then getting them 2 days apart. And then once the pregnancy hormone level is up around 2,000, you can actually do an ultrasound and you can make sure that the pregnancy is actually in the right location in the uterus, because you can see a gestational sac by then. You may not be able to see the whole embryo, but you can usually see the gestational sac, and know that you don't really have one in the fallopian tube, because what are called heterotopic pregnancies, where you have one pregnancy in the uterus and the other in the fallopian tube, those are really rare without fertility treatment. Those are about 1 in 10,000 pregnancies. So most of the time, if you just see a sac in the uterus, you're in pretty good shape. Now, if you have taken medication like letrozole or clomiphene, there is a possibility that you could have, a pregnancy in each location. And so that's why we look pretty early with ultrasound. And I really think that's probably a good idea just for the general population as well. It kind of just makes me really nervous when I hear about people and they'll be like, oh yeah, I'm pregnant, but they're not going to see me until I'm 12 weeks or whatever. I just think that's nuts. I saw a patient a while ago who had an unrecognized ectopic pregnancy, and she was trying to be, stoic about it and not complain. And it ruptured and she nearly died. And she bled so much that, they were able to take her to the operating room and they were able to stop the bleeding, but she had bled out so much that her blood coagulation ability had fallen off, and she had developed a condition called disseminated intravascular coagulation. And then that was very dangerous. And she had an intensive care unit admission and spent, many days in the hospital, and with every one of the team coming in and going, hey, oh, you almost died. Don't you feel lucky? So, my point is, I don't know how much that the insurer actually paid the hospital. I'm sure the hospital billed that admission out to probably around $80,000 to $100,000. And the insurer probably paid a fraction of that, maybe $20,000 or $30,000. But the whole point being, that could buy a whole lot of early pregnancy tests to give us a heads up with an ectopic, because ectopic pregnancies usually don't have a doubling HCG that goes up rapidly. So we want at least a 40 to 50% jump every 48 to 72 hours. And if you see that rise as being much more slow, then that's another, tip off that could be a tubal pregnancy. Other things that tend to be hallmarks for tubal pregnancy are pain and cramping, bleeding. So almost all of the tubal pregnancies that I have seen that have, not everyone, but most of them will have some bleeding and cramping, except the ones where we do the ultrasound really early and catch them much earlier. But yeah, bleeding and cramping and pain in early pregnancy, that needs to be investigated. So now most of the time you're not going to have a tubal pregnancy, but if you haven't seen the doctor, if you don't know where that pregnancy is, you need to get into the emergency room, because somewhere around 15% of those cases, it's going to be a tubal pregnancy and it needs to be diagnosed really early. So the ways that the pregnancies can be treated. Historically, the people were, really behind the 8 ball with this. The pregnancy would rupture. The patient would bleed out into her abdominal cavity, get really sick. Then they would do, they'd make a big incision in the belly. They'd take out the ruptured fallopian tube to stop the bleeding. And certainly that happens still, because if you get into trouble, you just really need to do it quickly and get control. But nowadays, if there's not too much bleeding going on, or if you've caught it before the pregnancy has started to bleed and bleed into the fallopian tube, getting ready to make it rupture, you can do what's called a laparoscopy. So you can put a telescope in through the umbilicus. You can put in some other ports through very small wounds that are around 5 to 10 millimeters, and you can go in and you can open up the outer surface of the fallopian tube, and you can shuck out that pregnancy and put it into a bag, basically a little plastic bag, so that you keep the rest of the fingers of that, or the chorionic villi, the part of the placenta that implants. You want to keep that away from the abdominal wall, because you don't want to accidentally seed some of that placenta into the abdominal wall, where it could maybe stick in there and cause some trouble. So then you can just take that out, and most of the time you can actually save the fallopian tube, because the biology of these things is weird. When those embryos implant in the fallopian tube wall, they just like in the uterus, they're digging into the wall and they're going down well into the fallopian tube. So they're not in the channel or the lumen of the fallopian tube, they're in the wall. So as they grow and they grow and they grow, then you can actually make that incision on the fallopian tube most of the time and actually pull them out, and the channel of the fallopian tube or lumen will not be damaged. So about 85% of the time, if you take out a fallopian or take a tubal pregnancy out of the tube, you can save the tube. So, and the tube may be perfectly fine down the road. So the risk of having another tubal pregnancy is about 15%. So that's something to keep in mind. So your risk would go then from 2% to about 15%. But still, hey, 85% of them are going to be in the right place. So, when people, have had tubal pregnancies, we try to reassure them and say, hey, look, it still is very reasonable to go ahead and try on your own with your fallopian tubes. Now, when people have had 2 or 3, or if they've had, more than one and they've had both of their tubes removed, you got to go on to IVF. But, and some people, even if they have their tubes, are like, that was so scary, I don't want to do it again, I just want to do IVF. But IVF can also lead to tubal pregnancies, just not nearly as much. So the stated risk for ectopic pregnancies in IVF is about 1%, but in practice, here in our practice, we haven't had one for many years now, and so I think what we're seeing is probably less than 0.25% for tubal pregnancy risk with in vitro. The other way you can treat tubal pregnancies, you can just follow them. I think that's kind of crazy, but historically, some of those pregnancies would just, they didn't have a good place to implant. They would just kind of go south. They would die and they would get resorbed, and the people wouldn't die. But typically, if you're not going to do surgery, then you use a medicine that's like an antifolic acid called methotrexate. And methotrexate is an injection. For most people, especially if you're catching it pretty early, there's not a lot of placenta and fetal tissue that's there. So you just need pretty much one injection, then you follow that out. You follow blood pregnancy hormone levels over time until they get down to 0. They can still rupture. I had a patient years ago who had methotrexate, and she ruptured her tube. Another complicating thing is that sometimes the methotrexate will give people abdominal muscle pain. So they'll get pain in the abdominal wall, and it gets hard to differentiate, because here we've told them, hey, if you have a lot of abdominal pain, get back into the hospital. And so, but they just have this muscle pain, and then, it kind of may trick them into thinking that they have an ectopic that's rupturing. For first ectopics, usually I recommend that you have the surgery, just because you want to be able to get the landscape of what's going on. So if you do the surgery, you can take a look at the other fallopian tube as well, and you can see if there's a lot of damage, a lot of pelvic adhesions around the ovaries of the fallopian tubes that might lead you to say, hey, look, maybe with another pregnancy, you just go right to in vitro and just declare bankruptcy on fallopian tubes. But it's up to, everybody has their own opinion with it. Again, if you're catching them early, catching early is really important. So if you have an early pregnancy and you haven't had blood pregnancy hormone levels, I would definitely get in with your doctor and do that. Just make sure that things are doubling appropriately with regard to those pregnancy hormone levels. So then after tubal pregnancies, if we're able to save the fallopian tube, we will usually go back in and do another what's called a hysterosalpingogram. So put liquid up inside the uterine cavity and watch it go out through the fallopian tubes. Now, that test, has a bad rap for being painful, but that was the old technique. And I know it was painful because, my spouse told me that in retrospect, it was more painful than having a baby. Yeah, some practitioners still use a bad technique where they inject the cervix with numbing medicine, which doesn't help, and it hurts like there's no tomorrow. And then they use a clip, a tenaculum, to actually grab a hold of the cervix and yank it down. That is barbaric. So, there's very little need for that sort of application. The way we do them, you put the speculum in, you wipe off the cervix with some betadine soap to kill germs that are there that you might flush into the uterus. And then you put a little rubber noodle catheter, which is about the diameter of a spaghetti noodle, into the cervix. And then you gently float some warm contrast up into the uterine cavity and out into the fallopian tubes. And for most people, it's kind of like menstrual cramping. Some people have no cramping with that technique. Other people, if the tube is really blocked and we're having to really try to see if it's open or not, it may be pretty nasty, but for the most part, it's not. We also pre-treat people for that test with ibuprofen or naproxen and a muscle relaxant called diazepam. And diazepam, the old trade name is Valium. It's also a sedative, but it's really good at keeping the uterus from contracting a lot, so it doesn't tend to hurt. So that test doesn't tend to hurt as much. Let me get to some of these questions that I have. So we talked about, and endometriosis is another cause of tubal problems. So endometriosis lesions can get onto the fallopian tube, and then they actually can interfere with proper motility of the fallopian tube. So you can go on Google and you can look up these pictures and Google pictures of endometriosis on fallopian tubes. But if you have those implants, they'll interfere with that peristalsis, or that sequential contraction that helps the fallopian tube bring the embryo back down into the uterine cavity. So the problem is when you do those surgeries for that and you find endometriosis on the tubes, you're really damned if you do, damned if you don't. I will usually take them off. I will try to skinny them off of the fallopian tube without using electric coagulation. But you potentially could damage the tube, but the tube is going to be damaged, one way or the other. But endometriosis then also, if it's on the fallopian tube, will increase the odds of tubal pregnancy as well. Maybe even if you don't have it on the fallopian tube, because of that just sort of global inflammatory, stuff that's going on in the pelvis, which is the body's reaction to endometriosis. So how do we determine if somebody has tubal infertility? Well, if they're not getting pregnant, we do this as a standard fertility workup. So we check the fallopian tubes with that hysterosalpingogram test. And if that's abnormal, then going to laparoscopy and taking a look at the fallopian tubes is very worthwhile. Fallopian tubes that have been really badly damaged to where they're closed off at the end or clubbed, those fallopian tubes sometimes can be salvaged and sometimes not. So typically what we will do is we'll open them up and take a look inside. And if the lining of the fallopian tubes, it still looks pretty good. And if there's fingers of the fallopian tubes, little fimbria, those tubes can have a decent chance of actually picking up an egg and getting that egg fertilized, getting it into the uterine cavity. If, on the other hand, they don't have any of that stuff in there, if they look like there's been a bad rip roaring infection with a lot of pus, which is, dead bacteria and white blood cells, from the white blood cells trying to kill off the bacteria, that really kind of stretched out the fallopian tube. A lot of the time that tubal lining will just be toast. You don't have the nice little thick, fluffy grooves and lands of the fallopian tube that are the embryology laboratory of the tube. So those tubes should probably be removed because they typically will, more commonly than not, just result in tubal pregnancies, if anything. Most of the time they will close back up, then they'll contain fluid that actually can kill embryos. So if you have a good tube on one side and then you have a distally or toward the end of the tube blocked tube, that blocked tube can generate liquid that can go down into the uterine cavity and destroy embryos that are coming in from the other side. So really badly damaged fallopian tube should really be removed most of the time. And then there's a question, but can you have a clear HSG but have tubal problems, or have a tube where the dye does not flow, but it is fine? And yes, that is, so that latter question, can you have a tube that looks black, but it's fine? Yes, because if you don't pre-treat the patient with the muscle relaxant and the non-steroidal, and you make them have a lot of cramping, the fallopian, their whole uterus will scrunch down and it'll block off the tube. It'll make the tube look artificially blocked. So if somebody has had a histogram that showed a blocked tube, especially close into the uterine cavity, and they say, hey, that thing hurt like a mother, then you probably should just repeat it because that tube is probably fine. And I've seen that dozens and dozens of times. And on the other end of it, you can have open fallopian tubes, but they may be damaged. One of the ways we kind of can tell that, and a little bit of this is just, you have to, like when I'm training, I train my residents on how to do these things. And you always want them to have a few that are really normal first, so they get the feel for how much back pressure there is when you're pushing that liquid in slowly, because usually there's very little back pressure. If the pressure is high, even if you're getting it through the fallopian tube, the likelihood that the tubes are going to work well is really pretty low. And there was a study out of a group in Chicago years ago where they hooked a pressure gauge up to the apparatus that they were using to instill that liquid up into the uterine cavity. And what they noticed was if the pressure got a lot higher, if it was like double, triple the normal pressure, the odds of those people actually getting pregnant, even if the tubes were open, was really, really low. How they used that information was interesting because that was a big fertility group, and they had contracted with all these people, all these employers in Chicago to provide fertility coverage. And the deal was they got paid a capitated or set amount for each patient. So they wanted to know, is it worthwhile to let those people try to get pregnant, or should we just stop and say, hey, let's cut our losses and go and take them to IVF and just get there? Because if we give them pill form fertility drug and we're doing inseminations, are we just spinning our wheels and we're just wasting time and money? So anyway, high back pressures are really are not good. So can indicate, and usually that's endometriosis or something like that. Let me see if there's questions here. So there's a question. What is the approximate percentage of success having one open tube and a good ovulation and a good response to ovulation medicine as compared to a regular person with both tubes and regular ovulation? It's actually very good. Okay. So the only, so if you have a good fallopian tube that's not damaged and you have lost one tube, either because it got damaged or a ruptured ectopic pregnancy, the chance of you getting pregnant with that good tube is still very, very high. So the majority of those people, I would say around 80% of them are going to take home babies. The problem can be, it's not predictable which side you ovulate from. So it's like a coin flip. I wish it was really predictable. You could say, hey, we're going to be able to, try to get you pregnant this month because this month you're going to ovulate on the good side. And you can actually pick up eggs from the bad side that doesn't have a tube. and that's called transmigration. But it's fairly rare. It's probably a 5% or less probability that you would pick up eggs over on that side. But it can happen, and we actually had one of those fairly recently, and of course I worried about it horribly, but it turned out to be just normal, good pregnancy. It didn't get stuck somewhere over on the ovary over there or whatever. Sometimes what we will do is say, hey, because we can't predict when you're going to be ovulating on the good side, we'll go ahead and give you pill form fertility drug to make you ovulate from both sides, so that there's a good chance that the fallopian tube can pick up an egg over there. The downside of that is, obviously, if you're ovulating, if let's say you got a left fallopian tube and you make 2 or 3 follicles on the left side, now you may have twins, or you may have a heterotopic pregnancy where one pregnancy is in the uterus and one is in the uterine cavity. But that's pretty much the rare thing. So, and then there was a question, what are the options for those with tubal infertility issues? Well, it used to be, we used to do just surgery for everything, because surgery was really the king. IVF was this poor stepchild because pregnancy rates were about 10% per cycle when I started my career. So you tended to do the surgery first, and you tended to try to maximize the fallopian tube. So if you went in there and tubes looked like they were capable of being salvaged, you would tease open the fallopian tube, you would fold the fimbria back, you would use mild electric cautery to kind of cause that fallopian tube to open up really nicely, so that it could pick up eggs. And you would use, kind of microsurgery techniques so that you'd had very little tubal damage from what you were doing surgery wise. But as time has progressed over the years, IVF has gotten much better. So pretty much if people are not getting pregnant with their own fallopian tubes, we just go right to IVF. Clearly, tubal factor patients are the most likely to get pregnant with IVF. So you need to be really careful with them to avoid multiples, because there's nothing probably wrong with their uterine lining receptivity. There's nothing wrong with, they usually, maybe they have tubal factor problems from endometriosis, but if they don't, if it was just from like chlamydia exposure or gonococcus exposure or something like that, then, or appendicitis. Sometimes when people have appendicitis, the fallopian tubes will be badly damaged just from the infection that's going on in the pelvis. But there's usually nothing wrong, embryo quality wise, egg quality wise. So, tubal factor patients, fortunately, then, it's a bummer to have to do IVF, but on the other hand, they have the highest chance of pregnancy of any group of patients doing IVF. So compared to the, endometriosis, male factor, low responders, all that kind of stuff. So that's a really good thing. So let me think if I can remember anything else about tubal pregnancies, but methotrexate. So methotrexate is this antifolic acid. And again, I've never seen anybody have trouble with it. I've had a couple of people where I had to give them a couple doses of it to get the pregnancy taken care of. Big thing. People are always like, they're like, hey, could I save that pregnancy? Because a lot of these pregnancies are really badly wanted pregnancies. And it's heartbreaking sometimes, because you'll actually see a heartbeat on the ultrasound, and that pregnancy is in the fallopian tube. And so people will always ask, hey, is there any way we could transplant that pregnancy into the uterus so that it could have a chance? And the answer is no. It's been tried. There's some sketchy stuff saying, oh yeah, we get this like 1% take rate. I wonder if those were like heterotopic pregnancies in the first place. But anyway, yeah, you can't, because they're uprooted. It's sort of like uprooting a tree, but then not being able to put the roots really in soil right away. So those pregnancies they have to be lost, which is really sad. But anyway, methotrexate can be used. If you use it, you don't want to take your prenatals while you're using it, because again, it's an antifolic acid. Folic acid helps cells that are dividing really rapidly do that. And so if you take away their folic acid, they tend to stop dividing. The rest of the cells in our bodies are not dividing really fast compared to those pregnancy hormone cells. And that's why the methotrexate works so well. If you give repetitive doses of it, there's some reports of people losing their hair Of course, it would be temporary, but no woman likes to lose their hair. So trying to catch those pregnancies early before they get really super well established and they're super big and may need multiple courses of methotrexate, I think is really the thing to do. And again, if it's a first ectopic pregnancy and the person wants to have kids, then or more children, pardon me, then I think doing the laparoscopy is probably better anyway for the first ectopic. If they don't want to have kids, then you got a bunch of different choices. If they say, hey, look, I'm done having kids, or I don't want to have children, then you can, do the methotrexate, certainly, or you can do laparoscopy and you can just take out both fallopian tubes. So fallopian tubes are great for reproduction most of the time, but they also are the cause of about 40% of what are commonly called ovarian cancers. So this is just a little caveat to kind of keep in the back of your mind. If somebody's going in your belly and you're done having kids, get rid of those tubes. That's a very easy operation for most people. It's not gonna, like, if you were going in there to, have a gallbladder, if you can get them to coordinate maybe with a GYN, that would be great. And you could just kill two birds with one stone. I mean, that can be hard in practice, especially if you're sick with the gallbladder problem right then, and it's, you need to have surgery right away. But keep that in mind, that, fallopian tubes, once they've done, serve their use, get them out of there. The appendix actually has a purpose, which is to be this little blind pouch that contains bacteria that will hopefully not get washed out if you got like cholera and or some other kind of Clostridium difficile or whatever, that you could actually repopulate your good bacteria in your intestine if you've got that appendix. But yeah, fallopian tubes, once you're done having kids and you have to have surgery anyway, I'd probably take those things out of there. Anyway, thank you all for saying hi. That's really nice. Some former patients, really nice to hear from you. So anyway, if anybody has any other questions about tubal pregnancies, ask them now, or if you think about them later, send us a message and I'll address them down the road. Other things that can make it higher risk: if you're over age 35, we touched on the smoking. So anyway, but the big thing is, I think that anybody who has a pregnancy should get in with the doctor, get blood pregnancy tests a couple of days apart, get their thyroid function checked, and then, be very proactive about it so you can catch those tubal pregnancies early. Certainly it's a lot. One benefit of that also is that, surgeries that you have to do in the middle of the night, a lot of the time it's not really the good OR crew that does GYN, it's fill-in. And so the doctor may be good, but people don't know where everything is necessarily in the operating room because they're not used to doing GYN cases. So diagnosing an ectopic pregnancy during the daytime is really much better if you're going to the operating room, because you got a regular GYN team. And if there's any risk that that the patient's starting to get close to rupture or is kind of in the process, then you can always bump other surgeons. And of course they don't like it, but you can always say, hey, dude, I got an ectopic and we got to take care of this lady. So anyway, so that's it. Call or messages if you have any other questions about tubal pregnancies, and tune in on September 24th for the polycystic ovary syndrome one. And I'll try to have other new facts about PCOS that may be relevant for folks. So have a great night. And I thank my coworker, Karina Bakame, who has made this possible, and we'll see you down the road.